with plenary session, the first plenary session, titled Maternal, Infant, and Child Nutrition and Health in Jordan. Many countries in the MENA region, including Jordan, have adopted policies and legislation to improve nutrition throughout the life course of women, infants, and children. Distinguished panelists in this session from the Ministry of Health, Jordan, and the World Health Organization, WHO, will share insights on the nutrition landscape in Jordan, national priorities, opportunities, and challenges for effective policy implementation, as well as the way forward to cultivate a supportive environment for the implementation of comprehensive nutrition policies in Jordan. Let's please, with a big round of applause, welcome on stage the session's moderator, Ms. Mariam Abdoh from USAID Jordan. And we would just advise you, please, to check the rich bios of all the moderators and speakers. You can find them in the booklets on your tables. Ms. Mariam, tfaddali. Thank you very much. The floor is yours.
Good morning, everyone. First, please let me express my heartfelt and sincere appreciation for all the participants and all the researchers who joined us today to this big event. And my heartfelt gratitude as well is extended to the organizers, the donor, and the University of Jordan who works on the research components. So for our first plenary session on maternal, infant, child nutrition and health in Jordan, I just want to highlight that many countries in the MENA region, including Jordan, has adopted lots of policies and legislations to improve nutrition throughout the life course of women, infant, and children. And today we have 4 distinguished panelists from the Ministry of Health, Dr. Anas Almohtaseb, Engineer Rawhiya Barham, and Dr. Hanan Najmi, and from the World Health Organization, Dr. Dana Darwish. Please join me to welcome them all to the podium. So our plenary session will just give us kind of like of understanding on the nutrition landscape in Jordan. It will shed the light on the national priorities, opportunities, challenges for effective policy implementation. Each presentation will take 15 minutes, and I would appreciate that our panelists finish on time. I'll let you know when there is 5 minutes left or 2 minutes left, so you can wrap up on time. One second announcement before we begin. So following the 4 presentations, we will welcome the questions from audience in person and online for our 4 presenters. And I would like to ask to add the questions for those who are joining us virtually on the Q&A Google Doc that will be shared with you. And we encourage questions, actually, and we would love, and we are looking forward to addressing them in a short while. So, for our first presentation, we would like to welcome our esteemed Dr. Anas Almohtaseb, who is the Director of Non-Communicable Diseases Directorate at the Ministry of Health, Jordan, to tell us more about a steps-wise survey 2020 and the NCD's risk factors in Jordan, with a focus on women in childbearing age. Dr. Anas Almohtaseb, in addition to his capacity at the Ministry of Health, he has a wealth of experience. He's a family physician and health economist, and he has a specialization in family medicine from the University of Jordan, and he also got the Jordanian Board in Family Medicine in 2014. He has also a Master's of Science and Health Economics from the University of York in UK. And he's also part of so many organizations. I encourage you to look at his distinguished bio. So please join me to welcome Dr. Anas to the podium.
Thank you very much, Ms. Mariam. And thank you for organizing this distinguished symposium and allowing me to talk about Jordan stepwise survey for non-communicable diseases risk factors that was conducted in 2019, and the results were announced in 2020. Actually, this was conducted before being the director of non-communicable diseases, so I am reporting the effort of my colleagues in the non-communicable disease directorate and World Health Organization, University of Jordan, and the support of USAID actually was crucial in conducting this study. Yes, I have this one. Okay. So, STEP survey was a standardized method of collecting, analyzing, and disseminating data related to non-communicable disease risk factors. It was conducted in more than 100 countries. In Jordan was conducted in 2004 and 7. The last one we are talking about, 2019, led by Minister of Health, implemented by Center for Strategic Studies at the University of Jordan and Minister of Health. Technical support from WHO, plus Minister of Health, and final report, funding actually from USAID. The scope of the survey, we have as you know, 5 major risk factors and 5 major non-communicable diseases. The non-communicable diseases are cardiovascular disease, cancer, chronic respiratory diseases, diabetes, and mental health, mental diseases. About the risk factors, we have tobacco, unhealthy diet, physical inactivity, and use of alcohol. Air pollution was added recently as another major risk factor. So, STEP survey, from its name, it has 3 steps. The first step is related to behavioral measurements, related to demography, behavioral risk factors, including tobacco use, physical inactivity, unhealthy diet, harmful use of alcohol, mental health status, air pollution. Step 2, related to physical measurements, prevalence of raised blood pressure, heart rate, overweight, and obesity. And step 3, related to prevalence of raised blood pressure, glucose, abnormal blood lipids, and abnormal sodium and creatinine in urine. So this is a biochemical measurement. Okay, the target groups, it was a random sample from Jordanian over all the nation, over all Jordan, and Syrians out of camps. So we have 3,000 Jordanian and 3,000 Syrians, and the data was aggregated into 2 groups, 2 age groups, 18 to 44 and 45 to 69. So regarding the sampling and the response rate, we are talking about response rate more than 90%, reaching 95% for step 1. Step 2, 93%. Step 3, about 63%, and the part of laboratory, about 78%, which is actually very good response rate and very important. This reflects the importance of this survey. So, starting with tobacco, use, we have actually it's better to look like this. So we have 42% of the Jordanians and 32% of the Syrians reported to be current tobacco smokers. Can we switch the slides to the second screen? Please. And we have from males are 65% was current smoker of tobacco. The percentage is less within females, about 16%. But also we have a quite high percentage of those who are using vaping. And second-hand smoking is another critical issue, actually. So about 3/4 of people reported exposure to second-hand smoking. And many of them were willing, actually, to quit smoking. Addressing that, the economic burden of smoking on the families. I just want to concentrate on another part, actually. No, I have to return back. Regarding the age group that we are concentrating on, which is women in childbearing age. So those who are from 18 to 44 years old, 17% of them are currently smoker, compared to 14% from those who are from 45 to 69%. Generally, the younger age group, the more prevalence of tobacco smoking, which is alarming for the future of tobacco consumption in Jordan. Going to diet, which actually the focus of this symposium. So we can see that the average number of servings per day of vegetables is 2, and of fruit is 1. 60% consumed 1 to 2 servings of vegetables or fruit per day. Only 18%, less than fifth of all respondents consumes 5 or more servings per day, which is the WHO recommendations. If you want to concentrate on the age group of women in childbearing age 18 to 44, we can see 14% just consuming the more than 5 servings and 10% no fruit or vegetables at all. So actually this is very alarming for us. About alcohol consumption, maybe the problem is very limited, and we might not have a quite big problem related to this issue. Most of who are lifetime abstiners are 99.7% are abstiners for females. Okay. About another risk factor that is important, prevalence of physical activity is about 25. We have 25% who were physically inactive. We are talking about 1/4 of the population are physically inactive. From those female, from aged 18 to 44, we are talking about 21 or 22%, which is quite high. Cervical cancer screening, this is another, we can see that percentage of women who have ever had a screening, about 12%, but it is less for Syrians, about 7.7%. Also, we can find that 18% of the population had depression, with a therapy range reported in 6.5 of patients only. I think that there is a problem in this. Okay. So it's better to ask you to move the slides. Thank you. Next, please. I have to run because the time is limited. So regarding just to comment about the prevalence of depression, in the past 12 months, we are talking from the childbearing age of women, about 22%, 23% of females are depressed in the last 12 months. Either they are currently on medications or they are fulfilling the criteria of depression. Next, please. Another important risk factor is overweight and obesity. We are talking about 29% overweight and 33% are obese. And for risk factors for women, we are in childbearing age, we are talking 60% are either overweight or obese. The prevalence of overweight and obesity in childbearing women is 60%, which is very high. Next, please. Again, about blood pressure measurement, 22% is the prevalence of raised blood pressure, and half of them currently not receiving medications. Half of them currently not receiving any medication. The percentage in childbearing women, about 10 or 11%. Yes, next, please. So we can see here more details about the coverage of therapy and control of raised blood pressure by age and sex. For females from 18 to 44 years of old, we are talking about 28% are already diagnosed, 28% only are already diagnosed. Oh, yes. So we are talking 28% are already diagnosed. So this is from your side or from my side? No, can we return back to that? Return back, please. Okay, so only 28% are already diagnosed and on treatment, and the blood hypertension is well controlled. We are talking about 44% raised blood pressure, not previously diagnosed, and some of them, 13% not on medication, 15% on medication but not controlled. Next, please. So the timer is lost now, so I can spend the time as I want. So about raised blood sugar, we are talking about 14% of respondents had either impaired fasting glucose or raised blood sugar or currently on medications. So, which is quite high prevalence. Maybe some other experts in diabetes might claim that we have a higher percentage of diabetes or raised blood impaired fasting glucose, but this is actually the result of this study, which should be more valid. Next, please. I have extra few slides. So yes, next please. So this is about raised blood glucose in the age group 18 to 44. We are talking about 5%. Next, please. About raised cholesterol, we have 18% raised cholesterol we have 19% raised cholesterol, 12% in women. Yes, 12% in women in childbearing age. Maybe the last slide, please. If we are, or we have another slide about salt. Next, please. Yes, next. Also, next, please. So, mean daily salt intake in all respondents is about 11 grams per day, which is higher than the recommended daily double WHO recommendation of 5 milligrams per day, and it's quite high in both sexes in all age groups. Next, please. Overall, if you want to comment on the overall risk, yes, oh, finally. Next, please. If you want to comment on the overall risk of cardiovascular disease, working now? يعني أن تصل متأخرا خير من أن لا تصل. That's good. Okay. أعين هناك؟ طيب. تمام. Okay. So, percentage aged 40 to 69 years with a 10-year cardiovascular risk equal or more than 30%, or with existing cardiovascular disease. So those who have cardiovascular disease or at high risk of cardiovascular disease, we have 25% of the sample have this characteristic. 16% of them are females. But if we want to talk about some of combined risk factors, current daily smokers, less than 5 servings of fruit and vegetables per day, insufficient physical activities, overweight, raised blood pressure, percentage with 3 or more of the above risk factors aged 18 to 44 years is about 33% in both sexes. 26% of them are females. This can alarm us about the future of the risks and burden of non-communicable diseases that we have to work all to tackle it and to decrease this risk because through healthy food, healthy diet, increased physical activity, and improving the mental health of the population. So thank you all. This is my last slide. Thank you very much. Excuse me, I have another meeting, so I will not be there for Q&A sessions. Maybe Engineer Rawhiya and Dr. Dana full aware about this survey and can respond for any question related to that. Thank you very much.
Thank you so much, Dr. Anas, for the impressive presentation. Can you hear me? Apologies for some technical issues. I wanted to thank Dr. Anas for shedding the light on so many important findings from the stepwise survey. We have seen how we have high rates of smoking, low rates of consumption of fruits and veggies, I mean, like the recommended five variable of fruit and veggies, and as well, like interestingly, an increase in the vapor smoking, and that's create really a heavy burden of non-communicable diseases. And we're looking forward for some questions in the Q&A session. I don't want to take more time. I would just want to welcome our second presenter, Engineer Rawhiya from the Ministry of Health. So please. Okay. So we're so pleased today to welcome Engineer Rawhiya. From the Ministry of Health. And just like want to welcome you in the most appropriate way. Engineer Rawhiya is the head of Nutrition Department, Primary Healthcare Administration, the Ministry of Health, Jordan. And she will present about nutrition situation in Jordan with a focus on infant and young children. Engineer Rawhiya, under her capacity at the Ministry of Health, is overseeing monitoring and evaluation of nutrition strategies, including food fortification and supplementation programs. She has a wealth of experience, and she developed and promoted food-based dietary guidelines and non-communicable diseases management guideline. And she led many national studies and assessments, and she has also published many studies. Please join me to welcome Engineer Rawhiya warmly to the podium. Thank you for being with us today. It's an honor.
كيف أجي هون ولا هون؟ صباح الخير. I will talk about the Micronutrient Deficiency Survey 2019 with collaboration with WFP, UNICEF, Groundwork, as well Jihaz.
ما في تايمر ما في تايمر
Yes.
I'll do the timer.
لا باجي هناك. Okay. Yes. The goals of Jordan Micronutrient Deficiency Survey is to provide an updated estimate of the coverage of adequately fortified bread in the household in Jordan, including the Syrian refugee camps, as well measure all the nutrition and health status of the key population in Jordan and the refugees, Syrian refugee camps, which includes preschool children aged from 6 to 59 months, school-age children aged from 6 to 12 years, as well non-pregnant women aged from 15 to 49 years, and a subgroup of pregnant women, as well to compare this result with the 2010 survey as impact study for the flour fortification program. The justification of this national survey is the data on micronutrient is available only from 2010, as well the data on malnutrition among the preschool children is from 2010. There is no available data regarding the zinc and sickle cell disease and thalassemia. Also, the Jordan Micronutrient Deficiency Survey 2010 collected information on the both under and over nutrition, as well lifestyle and dietary patterns. Sampling approach, we have 4 strata, North region, Middle region, South region, and all refugee camps. In each strata, we have 40 clusters. The second stage of sampling selected of a primary sampling unit from DHS. Within the selected primary sampling units, we select randomly from 15 to 20 households. The total household selected for this survey is 2,600. Sampling universe and scheme. Sampling universe is all households currently residing in Jordan. All members of following groups recruited from selected household. Preschool children aged from 0 to 59 months for anthropometric measurement and blood test. Assessment of also feeding from the blood test and assessing of feeding. The target group from 6 to 59 months for indicator based in testing blood. School-age children from 6 to 12 years selected from all households. Non-pregnant women selected from half of the selected household, and the pregnant woman any age in all households. The result for the preschool children in settled population. I concentrated here in the settled population because we have a limit time. So regarding the bread consumption, which is the main goal for the 2019 Micronutrient Deficiency Survey, to assess the coverage of the fortified bread consumed by the settled population in Jordan. The median daily bread intake for children from 12 to 59 months is estimated to 120 grams. The median proportion of iron intake from the bread is 68%. The prevalence of anemia is almost 12%. All the anemia is mild and moderate and no cases of severe anemia. Anemia prevalence is highest in the children during the first year, and it's gradually with age. It's classified as a mild public health problem according to the WHO classification. Iron deficiency, 26 of the preschool children were iron deficient. Age group and wealth quintile were significantly associated with iron deficiency. As well, 5% of the preschool children had iron deficiency anemia. Difference were found by age group. From 6 to 11 months, they have a higher prevalence of anemia, about 17%, comparing with the other age group, range from 2 to 7%. Vitamin A deficiency range from 4 to 8% depending on the retinol binding protein or serum retinol. The significant difference were found by age, high in the first year of old, and it is a mild public health problem. Vitamin D deficiency, 28% of the children, preschool children had a vitamin D deficiency. The total of vitamin D deficiency and vitamin D insufficiency is 61%. High prevalence of the preschool children with vitamin D deficiency is concentrated in the central region or the central strata. Zinc deficiency, it's a mild and it is estimated as 12%, and it is decline with age. The inherited blood disorder, the prevalence of hemoglobinopathies were low in the population of children from 6 to 59, and it's 0.2% had a skill cell mutation, 4.5% were carriers of at least one alpha thalassemia, 4% carried at least beta thalassemia. Because we have a low number of affected children, we don't have a further subgroup to be analyzed. For the malnutrition and overnutrition, 7.4% of the children were stunted, and it is low according to the WHO classification. Less than 1% were wasted, which is acceptable. And regarding the underweight, it's 2.7%. Also, it's low. And 9% of the children had overweight and obesity. According to the WHO and UNICEF indicators for the infant and young child feeding, for the early initiation of breastfeeding, it was not common. It was practice, yes. Practice in less than 2/3 of the children from 6 to 24 months. The prevalence of exclusive breastfeeding is very poor, as well continued breastfeeding for 1 year and for 2 years are not very common as well. The complementary feeding indicators, including introduction of solid. Well, I have some problem for concentrating in the slide. في introduction of solid food, minimum dietary.
الشاشة الكبيرة.
minimum dietary diversity, minimum meal frequency, minimum acceptable diet. Also, they are reasonable but not optimal. Yeah, the every breast indicator was common. The continued, yes, I talking about this one with the indicator number 3. Age-appropriate breastfeeding, predominant breastfeeding, they are relatively poor. And 2/3 of the children less than 2 years, they have received food from bottle in the last 24 hours prior to the data collection. Regarding the result of the non-pregnant woman in the settled population, the bread consumption was 250 grams per day, and the bread intake account for 20% of recommended nutrient intake in non-pregnant women. The prevalence of anemia was 24%, and it was high in the south region. Majority of the anemia was moderate or mild. Few severe cases were observed. And the iron deficiency anemia was very high. The prevalence was 66%, and with significant difference found by residents. 21.5% of non-pregnant women had iron deficiency anemia, and it was significant high in the southern strata. The prevalence rate was 34%, more higher than the north and or central. The prevalence rate was 21%. Vitamin D deficiency, only 3% of the non-pregnant women were deficient. As well, 11% they have folate deficiency. 90% of the non-pregnant women have vitamin B12 deficiency. Vitamin D deficiency was very high. The prevalence rate was 63.5%. I have to quick because, yeah. The undernutrition and overnutrition and obesity. Finish. Yes. I think I will talk from here. Yeah, the nationally undernutrition is relatively rare, 1.5%. We have 1/3 of non-pregnant women are overweight and 1/3 are obese. Yeah, Ajlun has the highest prevalence, and the prevalence increasing along with age, and after 35 years old, more women are obese than overweight. Excuse me. Yeah, the result of pregnant women, we have a subgroup, so we don't have a lot of data, except the dietary diversity was nearly 50%, and the supplementation was high, particularly for iron and folic acid. And the last slide is we don't have, okay, yes. The prevalence of anemia is 90%. As well, we don't have any undernutrition for the pregnant woman. And this is the slide, I put it as a spare to talk about the difference between 2010 and 2018 for the flour fortification program. Thank you very much.
Thank you, Engineer Rawhiya. Great presentation. And thank you so much for highlighting so many important findings from the micronutrient survey that it could guide us for future interventions or sustainable interventions within our health system. I would like to welcome our third presenter for the podium, Dr. Hanan Saeed al-Najmi, who is the head of Women Health from the Women and Child Directorate to the Ministry of Health, to give a presentation on breastfeeding policies. I'm quite sure there are going to be lots of interesting information in this presentation. So please join me to welcome Dr. Hanan to the podium. Thank you so much for joining us today.
Bismillah ar-Rahman ar-Rahim. Good morning, ladies and gentlemen. My presentation will be about policies, regulations, strategies. It's a tough presentation, but I hope it will be interesting to you. In the beginning, I will tell that feeding practices in the first 1,000 days of baby's age is very important, short term and long term. Short term, it will affect his growth, his nutrition, and long term, it will affect his morbidity. It will prevent him from diseases, from chronic diseases. So it's very important also when he is a fetus, the maternal nutrition. So the first 1,000 days of baby's age is very important and will give better outcomes for health and production in the society. My presentation will be about policies in Jordan. I will talk at first about global efforts that was done to promote, protect, and promote breastfeeding. Hi. Okay. Hi. Okay. Hi. Okay. Thank you. I will talk first about the global policies, the efforts done by globally to support and promote and protect breastfeeding. Then I will talk about the joint report of WHO UNICEF, which is a study done to see the impact of marketing of breast milk substitutes on feeding practices. I will talk about the Jordanian Code of Marketing of Breast Milk Substitutes, and I will talk about breastfeeding policies in MOH and about the legislation supporting breastfeeding in Jordan. I will talk about the milestones globally. You know that in 1981, the International Code of Marketing of Breast Milk Substitutes were launched, and there was a consensus about that. Even Jordan approved that code. Then in 1989, there was the 10 steps for successful breastfeeding, which will address the early initiation, exclusive breastfeeding, on-demand practice. It was in 1989. Then the launching of 1991 of Baby-Friendly Hospital Initiative. It was done because there was many harmful practices in hospitals that will market and practice breastfeeding formula for babies delivered in the hospital. So many studies approved that when you put the 10 steps in these hospitals, the breastfeeding indicators will improve. Jordan at that time accepted this and begins this initiative in 1995. There was baby-friendly hospitals in Jordan. You know, I'm old, I know the history of breastfeeding in Jordan. In 2002, there was the global strategy of infant and young child feeding. And also, we practice this in our MCH centers, in antenatal care, postnatal care, in child health, everything, early initiation, exclusive breastfeeding, and we monitor this in our MIS system and the electronic system for monitoring these reports from our MCH centers in Jordan. In 2005, there was a call to action to revitalize the Baby-Friendly Hospital Initiative because there was decline of the number of breastfeeding or Baby-Friendly Hospital Initiative. In 2009, there was a guidelines about baby-friendly hospital initiative. There was tools to assess the baby-friendly hospitals. And also, in the Ministry of Health, also we use the tools to assess the baby-friendly hospital in Jordan. The most important things about our challenges is that it was certified as baby-friendly hospital because it achieved about 80% of the 10 steps. But after that, when you do assessment again or reassess the hospital, it will decline. There was no sustainability in this issue. In 2016, there was a global baby-friendly hospital initiative congress in Geneva, and they discussed the challenges which was in the guidelines of 2009. And from the conference, they established new guidelines. It is 2017, and there was minor differences between the 2009 and 2017. They include the prematures and the full term, and they also establish monitoring and evaluation system to be in the 10 steps. And also they strengthen the code to be the first critical step in baby-friendly hospital initiative. In 2021, there was the 40th breast milk anniversary. It was online, and I attended this meeting, and there was a lot to say about marketing of breast milk substitutes all over the world, even with COVID-19 crisis. And in this issue, I would like that to ensure, and we owe it to our children, to ensure that mothers are protected from these unethical marketing practices everywhere, and to be equipped, our mothers, with evidence-based information and support to protect breastfeeding. This report, I told you, it was led by WHO and UNICEF. The study was conducted in 8 countries. It is Bangladesh, Mexico, Morocco, Nigeria, South Africa, UK, and China, Vietnam. I will talk fast about the results. But this research shows that formula milk, as $55 billion per year, industry systematically undermine parents' infant feeding decisions and compromise women's and children's health and human rights. This is very important. Marketing should not be with food for the under 2 years of age. It's very risky, really. You can market for anything else, but for the nutrition of the baby, you should not market. You should put your best practices. The results, overall results for this 22 study, formula milk marketing was pervasive, personalized, and powerful. طبعا formula milk companies use manipulative ways to market, and they exploit parents' anxieties and aspirations. برضو the milk companies distort science to legitimize their claims about their formula. They sometimes tell the mother that it is comfort milk. The baby will cry less, the baby will sleep more. Sometimes they address the gender issues. Your husband can help you, he can give the formula and you can relax. Even they idealize formula milk, and this is not good, and this conflict of interest, I think. Industry systematically targets health professionals. I am very anxious about that, because their recommendations to mothers are very influential, and the mothers will obey their orders for the doctors. So this is very important and risky, because when you see the results, many marketing was done from the healthcare professional. Okay. The findings, about half of the pregnant and postnatal mothers reported that they are seeing or hearing formula marketing in the previous year. Also, self-reported exposure to marketing is highest among women in urban China, 97%, 92% in Vietnam, and UK, 84%. Women in the 8 study countries reported receiving free samples. In the hospitals, the free sample of formula and other things are given to mothers. So this is a very bad situation. Across the 8 countries, there was strong desire from mothers to breastfeed. 49% of women in Morocco want to breastfeed, 98% in Bangladesh. Even if you see our DHS in Jordan, in DHS 2017 to 18, about 92% women will begin breastfeeding, but after that, the practices are not good. So the desire to breastfeeding is there in our mothers, but the marketing sometimes will let her change her mind from breastfeeding to formula feeding. Marketing messages reinforce myths about breastfeeding, as I told you before. They said that the necessity of formula in the first days after birth, your milk is not sufficient, the insufficient milk syndrome, the perception that formula keeps infants fuller or for longer time, sleep more, cry less, you'll have rest more. They advise that the husband will take care of the baby. The quality of the breastfeeding declines with time. This is what the messages they tell to the mothers, and the mothers have, and they adopt these messages and tell them to other mothers even. Health professional recommendation to use formula milk were common across the surveyed countries. In Bangladesh, 60% of postpartum women, and in Nigeria, 45% had received recommendations from a health professional to feed a formula product. And this is very dangerous numbers, because this is conflict of interest, and any healthcare provider should counsel the mothers about the best practices and infant and young child feeding practices when there is no medical condition to have formula. Many companies seek to influence health professionals' understanding of breastfeeding, to convince them, mothers, to have formula and to use them as channels for milk marketing, formula marketing. This is very dangerous. And this results, I think, that in Jordan, we noticed that many healthcare providers market for formula. Even this study results can be generalized everywhere, because we noticed here in Jordan, healthcare providers have many gifts to go for trips in order to market the formula. This is well seen in Jordan. I hope this will be less. About the Jordanian code, it is, Bardo, there is a history of this Jordanian code. It is dependent on the public health law and on food and drug law, okay? In 1996, there was regulation from the minister about the infant and young child practices, like early initiation, exclusive breastfeeding rate, about not marketing breast milk substitutes, not giving donations for hospitals, all the things. And also in 2009, there was national code, but the problem is it was not making penalties for those who violate the code. So in 2015, the national law, which is the Jordanian Code of Marketing of Breast Milk Substitutes, was established, and it was approved by the cabinet, and it is guidelines from the minister. The summary of the code was launched in 2018, and the implementation was in Jordan begins in 2019. The most important, this is the code, and this is the ta'limat or regulation, and I want to stress on Article 7 of the guidelines of the minister that he ordered the hospitals and the health facilities to practice the infant and young child feeding practices. It is obligatory, but sometimes the response is not so good. So it is there in our code. The main points is no advertising of breast milk substitutes and other products to the public, no donations of breast milk substitutes and supplies to the mothers or the healthcare providers, no free samples to mothers, no promotion in health services, no company personnel to advise mothers, no gift or personal samples to health workers, and this is very important. Regarding the policies in Jordan, we have adopted the infant and young child feeding strategy since 2002. We have the initiative, Baby Friendly Hospital Initiative. We have also the breastfeeding policy that is launched by the Ministry of Health, and we have legislation regarding the working mothers. The global infant and young child feeding, it is about early initiation, which the indicator is 67%, the early initiation of breastfeeding in Jordan in the first hour. Exclusive breastfeeding, it's very important. The rate is 26% in Jordan, according to the last survey. And adding complementary feeding at the end of the 180 days of the child's age, and continue breastfeeding 40 years or beyond. This is the strategy that we are adopting in Ministry of Health. The 10 steps, there is no time to speak about it, but it is very important. And we now, with the help of HCAC, we are doing this initiative, and many hospitals are certified as baby-friendly hospital in Jordan. This is very fast about the code, the policy, number 1, and the monitoring and evaluation. Number 2, about the competency of healthcare providers and training them. Number 3 is about preparing the pregnant woman to breastfeed in the first hour and skin-to-skin contact. The 4th one is care right after birth, to help the mother to exclusively breastfeed and help her after delivery with 6 hours, to help mothers for positioning and attachment for any difficulty in breastfeeding. 6, to ensure that every mother delivery in the hospital is exclusively feeding her child. Number 7, rooming in. The mother with the baby should stay together for 24 hours unless there is medical condition to separate the baby. Responsive feeding, although it is one from the most important things. And bottle, teats, and pacifiers, the danger signs of them. Discharge, there should be a discharge note with the mother in order, if she has any breastfeeding difficulty, to go to the MCH center, to go to mother-to-mother support groups. There should be something written in the hospital to have access to it, the mother, when she is discharged from the hospital. Breastfeeding policy, was launched in 2015, okay? And the most important things in it is hospitals and health center follow the 10 steps of baby-friendly hospital initiative. All health facilities should not violate the code in any means. Promotion of breastfeeding counseling, and helping mothers in antenatal care, postnatal care, and delivery services according to the guidelines. Help working mothers and also lactating women how to express milk and how to keep it if they have need to that. Counseling the infected mothers with COVID-19 on how to breastfeed with certain precautions, and referral for mother after delivery to MCH centers for postnatal care to have counseling about breastfeeding and other things. But the last slide will be about the laws. You know that in the labor law, the pregnant woman after delivery can have unpaid leave for about 1 year, and she has 70 days as maternity leave after delivery. In the Royal Medical Services and in the government, we have 90 days maternity leave. Okay, and we have 1 hour leave till the baby is 1 year of age to let the mother go and breastfeed him. And the last is the role of Ministry of Health in preventing marketing by the code, by the public health law, and the drug and food law. And that's it. Thank you very much. Breastfeeding is the best.
Thank you, Dr. Thank you, Dr. Hanan. Great presentation, and thank you so much for shedding the light on a very important issue, which is the breast milk substitute marketing and how we can tackle that through educating healthcare providers. Dr. Hanan came with a really wealth of practical experience, and I encourage you to look at her bio on the bio book, on the abstract book. We have our final presenter, who is very dear to all of our hearts, Dr. Dana Darwish from the World Health Organization. She is the focal point of contact for non-communicable diseases, and she will be presenting about policy brief on healthy diet for all in Jordan. She came with really a wealth of experience, and she is a doctor in pharmacy. I encourage you to look at her bio, and please join me to welcome her to the podium. Thank you.
Next. Okay. Good morning, everyone. It's a real pleasure to be with you today. I'd like to salute you on behalf of World Health Organization and my other very dear colleagues around the room from other UN agencies, UNICEF, WFP, UNHCR. especially that I will be presenting about a document that was a very good example of joint work between our UN agencies. It was a UN policy brief for healthy diets for all in Jordan. In early 2021, the United Nations country team in Jordan called for developing UN policy briefs that outline recommendations on various topics. One of them was nutrition. So basically, this policy brief was released on the 23rd of September to coincide with the UN Global Food System Summit. So basically, and it was, as I said, a joint work between World Health Organization, UNICEF, WFP, the World Food Programme, and FAO. So basically, I won't go that much through the nutritional situation in Jordan, given that my colleagues already covered that. So I will just try to fill in the gaps and provide some new information. So the policy brief outlines about the strategies, policies, and the available institutional frameworks. And to be honest, over the past 5 years, Jordan was active in this sense, whether updating existing strategies or developing new ones and substantiating them with action plans, as I will explain now. So basically, Jordan ratified the UN Covenant on Economic, Social, and Cultural Rights in 1966, which outlines key elements to the right of health and the right of food. And as you know, that adequate nutrition is an essential component to both of them. In addition, last year, the Ministry of Health, with support of UN agencies and a wide array of nutrition and food system stakeholders, developed the National Food Security Strategy.
Sorry to interrupt you. I think the slides are not moving, so
yeah.
Maybe you were in the...
Yeah, pardon me.
Yeah.
Yeah, this is the one.
Yeah, great.
Okay. So, forgive me. I was passing it on one screen and I forgot the other one. But it's important that I see what I'm saying. So basically, back to what we were mentioning about the food security strategy, which spans over the year 21 till 2030, actually. It was a very good chance for all the stakeholders, and I was one of them, to witness the active dialogues that went around the future for the food security and sustainable food systems in Jordan, and there was as well an action plan developed. It should be, and it is endorsed as well by the Prime Minister and the Minister of Health. However, the launch is to be sometime soon. In addition, there is as well a national strategy for school health spanning from 2018 till 22, and it is about to be as well updated. However, it discusses the nutrition at schools. When this policy brief happened, the nutrition strategy wasn't still existing, and this was one of the, let's say, things driven further by the UN policy and the very active initiative taken by our very active focal point for nutrition at Ministry of Health. The ministry requested support in developing the national nutrition strategy. The work is on progress, and I would like to salute Engineer Rawhiya for her very dedicated efforts in this regard. So we are expecting a launch in October of this year. The strategy spans from 23 till 2030. Different stakeholders were there. I am as well happy to see in the room some of the personnel who were involved in the nutrition situation analysis that formed the base for this. It as well involved discussions of the priorities of Jordan in terms of assuring adequate and healthy nutrition throughout the life course of all groups and responding to the immediate and the longer-term needs of Jordan. In addition, there is a framework of Action for Obesity Prevention by the Ministry of Health, technically supported by WHO. It outlines several strategic interventions to strengthen the prevention and the management of the risk factors related to different areas, whether it is the marketing of foods, the food reformulation and regulations, the breastfeeding, the physical activity, health at schools, etc. In order to maintain and to ensure the enactment of this, of the interventions in this framework, there is a multi-sectoral national committee which I also see so many of its members around the room, and it convenes every 2 to 3 times per year to follow up on the progress achieved in terms of the different aspects. The Ministry of Health in 2020 developed 2 valuable guidelines, the food-based dietary guidelines for public and another one for non-communicable diseases, and all of these documents are now available at, on the web site of the Ministry of Health, which I highly encourage you to go through them. As well, we must as well mention here the initiative by the Ministry of Health along with the Jordan Standard and Metrology Organization, and it took very active steps in terms of reducing salt in some of the very highly consumed commodities such as bread. The policy as well, of course, mentioned some of the nutritional context in the East Mediterranean in Jordan. However, to mention here, the East Mediterranean regional strategy for nutrition highlighted the prevalence of undernutrition remains high in the region. However, as mentioned by my colleagues, it's not that big of issue in Jordan. However, the burden of overweight and obesity remains very alarming. And in Jordan specifically, we have a double burden of micronutrient deficiencies and the overweight obesity. And since the number is very alarming, I thought of just including and emphasizing it one more time. So we have an overall of 61% overweight and obesity, and the number can go up to 90% in women, 45 up to 69, which calls for a collective joint work to address this issue, especially that it is related with a very high rate of non-communicable diseases. We have 1 in 5 has high blood pressure, and we, as my colleague in the morning mentioned, the very high consumption of salt. We have 1 in 5 that are suffering from diabetes, and it is, as you know, very highly associated with overweight and obesity, along with an array of other risk factors. In short, so we conclude with the recommendations that this policy brief came up, and we would hope and work together to support Jordan in enactment of these recommendations. So the adoption of regulations for the marketing of food products to reduce the marketing of those high in saturated fat, trans fatty acids, salt, and sugar for children, adults, adolescents, mothers, and other groups. Scaling up the food reformulation to achieve the same goal of the reduction of salt, sugar, and saturated fats. The taxation of soft drinks and others high in salt, sugar, and fat, to subsidize the access to healthy foods and educational campaigns on healthy diets. It always remains a need to invest on the campaigns, as education is a right in order to make informed decisions. Implementation of mandatory standards for food labeling, and I as well must mention here the initiative or the action taken by the Ministry of Health in this regard with the support of WHO last September 30th, 2021. There was a workshop that discussed the introduction of food labeling, and the ministry has been following with JSMO, the Jordan Standard and Metrology Organization, in this regard, and we will be seeing some implementation in the very near future. Yeah, and it was approved, yeah. As we said, the development of the National Nutrition Strategy, this has been also already reflected and enacted. Development of an action plan, and actually to update the school health strategy, and the implementation of the food security action plan. Setting standards for public procurement and provision of healthy foods, and I must mention a very interesting experience within the Committee for the Obesity Prevention, the reduction of the salt in menus serving the hospitals of Ministry of Health and the Royal Medical Services. This was as well one of the things discussed and achieved. Providing balanced and healthy school meals and supporting the already existing school feeding programs is a priority. Scaling up and implementing monitoring of pesticides in foods. There is as well in the meantime running the Ministry of Health, along with the Jordan Food Drug Administration and support of WHO, total diet studies, which entails the assessment of the food consumption patterns within the Jordanian, within the population of Jordan, accompanied with the estimation of a list of chemicals in those foods so that we can quantify the amounts of chemicals ingested by the population. To follow up, so establishing a nutrition monitoring system, and there are ongoing discussions about nutrition surveillance system establishment and integrating them within the already existing surveillance system within the Ministry of Health. As Engineer Hanan mentioned, the complying with the International Code for Marketing of Breast Milk Substitutes, highlighting the low rates of breastfeeding in Jordan, which as well makes it a priority. However, we can see some progress and promise with the baby-friendly hospital initiative run by the Ministry of Health, the Health Accreditation Council, USAID. Raising awareness on health food consumption is a must, and I would like to end up with ensuring the right to education. People must know what they're eating, and they have the right to understand it so that they can do informed decisions about it. And we would like to have all our efforts joined together so that we can achieve better health, better nutrition, better access to healthy foods in Jordan. I come to the end of my presentation. Thank you so much for your time and listening.
Thank you so much, Dr. Dana, for the great presentation. And I think we've seen through the presentations how they have a burden of non-communicable diseases. I mean, like, we went through some situation analysis, some recommendations, but we see, like, also from all the collective information that we got from these presentations, how they have a burden of the non-communicable diseases, really in need for collective support from all stakeholders to minimize the risk factors in Jordan. And it's just like a multi-sectoral multi-sectoral in its aspect, and it needs like a very collective efforts from everyone. So with that, we come to the end of our plenary session. I'll open the floor for some questions, and to be cognizant with the time, we run actually out of time. So we will take only 1 or 2 questions if you allow us. So if anybody has any question. Yes, please.
Hi, my name is...
If you can just like mention who do you want to, from the
yes, of course,
our plenary session to answer your question, or if you want to address it to everyone.
Yeah. My name is Dara. I work with the United Nations Relief and Work Agency for Palestine refugees. My question to Rawhiya. So thank you so much for your presentation. Obviously, this is a good reference for a lot of studies and future studies. So for the, specifically for the stunting you mentioned is 7.4 for children. Could you share more about the method, how you measured the stunting 7.4? Because if it was household survey, or is it primary healthcare from primary healthcare setting? Because I just wonder if it's really representative of the population in Jordan. Thank you so much.
I think we have a portable test.
Hello? Yeah. Regarding the stunting, as I mentioned in the first slide, in the second slide, the scheme of the survey was to use the anthropometric measurement. So we use the height for age. This is the indicators for the WHO indicators. Yani this is, and we plot. Yes. We have a plot of the graph.
Yes.
At the growth chart for the height for age.
Yes, but the question, was it from household survey, community level, or the primary healthcare level? That's
no, this is in the survey, in the field.
Okay, thank you.
No. The result the result shown here is from the survey of 2019. Yeah, it's in the real situation of the field. Yes, at household. Yes, I mentioned that in the beginning of the presentation. Yes.
Thank you, Dr. Rawhiya, for answering the question. I wish I can take more questions, but I don't want to delay you from the lunch break. So you can continue your discussion and your questions and by addressing them directly to our esteemed presenters. Thank you so much for joining us today.
Thank you very much, Mariam.